Thank you, and welcome to the Dapanorm Conclave, hosted by Alchem Laboratories. It is a pleasure for us to have a lot of our
Recording in
delegates here
progress.
to enlighten us on the topic of SGLT2 inhibitors, cardio-renal benefits, and beyond, with the focus on Dapagliflozin. I'm Dr. Samir Guliani, representing Alchem, and it is my pleasure to welcome our chairperson, Dr. S.K. Sharma, our moderator, Dr. S.C. Manchanda, our international
ये कितना
faculty,
है अटेंड, ये मुझे क्या 9 दिख
Professor
रहे हैं?
Andrew Coates, with our national faculty also Dr. Ashu Rastogi and Dr. Deepak Ranjan Das. Today evening, this would be our agenda of the program with Dr. Sharma, our chairperson, who will brief us on the entire program, with handing it over to Professor Coates, who shall be our international speaker, giving us the insights on dapagliflozin and the cardio-renal benefits on the same. We'll have a session which is moderated by Professor Manchanda, followed by a case discussion by Dr. Rastogi, and also another session by Dr. Deepak Ranjan Das on the usage and importance of SGLT2 inhibitors in Indian practice, followed by the question and answer session. So while this audience gets settled in their seats, it's my pleasure to also introduce our speakers, Dr. Professor Coates, who is from the Royal Australasian College of Physicians in Australia. He's the current president of the ESC Heart Failure Association, an experienced academic leader and entrepreneur with 3 decades of international experience in 4 of the world's top 50 universities. He has over 750 peer-reviewed full papers, over 110,000 career citations, and an H index of 139. He has been named one of the top 1,000 researchers of all time by the Webometrics ranking of the world university. He is the author of more than 20 awarded patents. He has held 12 visiting professorships at major universities and has given more than 200 invited lectures at international conferences. He has also been awarded with 46 major keynote or prize lectures, received many scholarships, distinctions, prizes, and awards for extensive research in the field of heart failure. Welcome, Professor, on behalf of Alchem. Moving ahead, we have our pleasure, sir. Dr. S.C. Manchanda, who is a consultant cardiologist out of New Delhi. He's a senior consultant, Department of Cardiology at Sri Gangaram Hospital, New Delhi, and the former professor and HOD of cardiology at the Premier Institute of AIMS. Over experience of 45 years in teaching and research, he has published over 400 scientific papers in various national and international medical journals, including 50 chapters in the standard medical books. He has authored 4 books, including the Orum's Clinical Heart Disease, and he is the recipient of the Padma Shri Award by the President of India and the Lifetime Achievement Award by CSI, along with many national and international awards. Welcome, Professor Manchanda, to our forum here. Further, also, it's my pleasure to introduce Dr. S.K. Sharma, who is a consultant endocrinologist at Jaipur, graduate from the PGI Chandigarh. He's currently working as a consultant endocrinologist at the Galaxy Specialty Center at Jaipur, the ex-professor of medicine at Mahatma Gandhi Institute of Medical Sciences, published over 26 research publications in various index journals, awarded by the Times of India, the Rajasthan Health Award Endocrinologist in 2013, awarded by the RSSDI at the 5th Annual Conference in 2017 as the Distinguished Service Award, and also awarded by the Economic Times as an Inspiring Endocrinologist of India. Welcome, Dr. Sharma, to our forum. Further, we have Dr. Ashu Rastogi, who is an associate professor at the Department of Endocrinology at the PGI Chandigarh. He has published over 95 research papers in indexed international and national journals. He is the recipient of a Young Investigator Award by the AACE of United States of America in 2012. Also received many Best Research Paper Awards and Oriation Awards. He is currently the Vice President of the Diabetic Foot Society of India, the Treasurer at RSSDI, the Punjab chapter, an executive committee member of the Endocrine Society of India, and he is a principal investigator for various phase 3 and phase 4 trials related to diabetes. Welcome, Dr. Rastogi. Moving on, we have Dr. Deepak Ranjan Das, who is a consultant cardiologist from Cuttack. He's a faculty at the Department of Cardiology at the SCB Medical College and Hospital, Cuttack. Teaching experience of more than 15 years, a reviewer of the Indian Guidelines of Hypertension and the Indian Heart Journal, contributed chapters in textbooks, and has more than 60 publications in the indexed medical journals. Welcome, Dr. Das. So it has been a privilege to introduce all our speakers and faculty for today. I'll hand it over to Dr. S.K. Sharma, the chairperson, to take us further, please. Thank you.
Thank you, Dr. Samir. Thank you very much. We are all, I should say, thanking Alchem for providing us so distinguished speaker, Dr. Andrew Coates, as well as Dr. Manchanda. We all know Dr. Manchanda, and Andrew Coates is the chair in the heart failure in ESC. And today we are going to learn a lot about diabetes and cardiovascular disease, and of course, what is the role of these SGLT2 inhibitors in the management of diabetes and beyond diabetes. So dear friends, things have changed. History is turning. We see that earlier our approach for the treatment of diabetes was that how effectively we can reduce HbA1c of our patient fasting postprandial. But then we realized that diabetic patients are having more risk of cardiovascular disease. So we started looking at the risk factor for the cardiovascular disease. And then, of course, the things were again changing. And then a concept of organ protection came in after all these cardiovascular outcome trial and renal outcome trial of many of these newer anti-diabetic drugs, particularly SGLT2 and GLP-1 receptor agonists. So earlier we were all worried about, you can say, coronary artery disease. But now we know that gradually, after looking into all those risk factors, coronary artery disease is reducing. But Dr. Andrew will be highlighting, even in spite of reduction in coronary artery disease, we have a huge burden of heart failure in our diabetic patients. And we all say that diabetes is an independent risk factor for the development of heart failure. And of course, 40% to 50% of our diabetic patients are also developing nephropathy, diabetic kidney disease. And with the advent of all these landmark cardiovascular outcome trial, right from the EMPA-REG outcome, CANVAS, and of course, declared TIMI, we all realize that these are the group of drugs which are not only preventing development of heart failure, but also subsequent studies like DAPA heart failure, Emperor reduced, and now DAPA CKD is there. And recently concluded Emperor preserved studies are telling us that there is more to these SGLT2 inhibitors. They are considered to be beautifully looking into all the aspects, not only hyperglycemia, but cardiovascular as well as renal, you can say, prevention and protection. And then, of course, we realized that these are the drugs which are far, far effective and can be given right from the beginning. And our patients are also having, like diabetic patients are also having a subclinical cardiovascular disease. And in all those things, you find that these drugs are beautifully tackling all those problems of our type 2 diabetic patients. So this is my take on. And another important point we can say that the mechanism of action of all these good effects are still evolving. So we don't know much about what is the basis of these benefits. So we keep on searching, and probably Dr. Andrew will be highlighting some of these newer mechanisms of actions of these, you can say, mechanisms behind the benefits of SGLT2 inhibitors. Thank you very much. Now we can invite Dr. Andrew Coates for his presentation.
Thank you very much, Dr. Sharma, and thank you to Alchem Metabolics for bringing us together in this Dapanorm Conclave. Let me get my talk up. So I will be talking, as said, about SGLT2 inhibitor cardio-renal benefits beyond, with a focus on dapagliflozin. I'm president of the Heart Failure Association, and here are my declarations. We've had very many treatment trials in heart failure with reduced ejection fraction that have improved mortality and morbidity. It's the area of medicine with the most separately proven treatments. We've gone from vasodilators through a number of neurohormonal antagonists and modulators, culminating in sacubitril/valsartan, and then some other treatments such as devices, non-pharmacological treatments. But a new drug class has emerged in the last few years, as has been mentioned, with dramatic benefits on our patients with heart failure, and they're the SGLT2 inhibitors. And I'd like to concentrate on those trials to what we can learn about their mode of action and effects. This story came because type 2 diabetes and heart failure very frequently coexist. About 30% of patients with heart failure also have coincident diabetes, and that percentage is going up in many countries and also in India. There's also about a 2.5-fold higher rate of chronic heart failure in patients with type 2 diabetes compared to those without type 2 diabetes. When we have diabetes, it puts the risk of cardiovascular death or heart failure hospitalization much higher. So you see here, patients with heart failure and reduced ejection fraction, their cumulative incidence of the combined endpoint is substantially higher than patients without diabetes, irrespective of whether they have heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. So, of course, there was interest whether better control of diabetes would lead to better outcomes and fewer episodes of heart failure. But here we see an analysis looking at a meta-analysis of 4 studies that randomized patients to more aggressive glucose control in diabetes compared to less aggressive. And you see that overall, there's absolutely no difference. So there is no benefit of increasing the quality of diabetic control in terms of HbA1c in trying to prevent episodes of heart failure or fatal heart failure. It seems that the glucose level does not materially affect the risk of heart failure within the normal treated range. As has been mentioned, there are also a variety of newer agents introduced for the treatment of diabetes. And of course, they vary in their ability to reduce glucose and can vary in their ability to prevent major adverse cardiovascular episodes. But when many of these agents were tested, then the incidence of heart failure hospitalization varied. And you see that for many agents, there was no difference at all. There was no value in having the newer drug compared to established ways of treating diabetes. But there are a couple of outliers. The DPP4 inhibitor, saxagliptin, actually led to a significant increase in the risk of heart failure hospitalization, and hence it should not be used in a patient at high risk of heart failure. And both of 2 agents that are thiazolidine diones or glitazones led to a substantial increase in the risk of heart failure hospitalization. So they're also contraindicated to treat diabetes within the presence of heart failure. They were pioglitazone and rosiglitazone. So you see no drug of these major drug classes reduce the incidence of heart failure hospitalization, and several drugs actually increase the risk. Therefore, when they were developed cardiovascular outcome safety trials in the development of new type 2 diabetes drugs, it was quite a surprise when we started to see a major reduction in the risk of heart failure hospitalization. We've seen 4 programs that have reduced the relative risk of heart failure hospitalization from 35, 33, 27, and 30%. And they were the EMPA-REG outcome trial of empagliflozin, the CANVAS program with canagliflozin, the DECLARE-TIMI program with dapagliflozin, and VERTUS with ertagliflozin. So in terms of preventing heart failure hospitalization, we're seeing for the first time this major drug class having a substantially different and more beneficial effect on heart failure in patients with type 2 diabetes compared to any other anti-diabetic agent. This is shown here in a meta-analysis of the 3 most extensively proven drugs in this class, empagliflozin, canagliflozin, and dapagliflozin, showing a substantial benefit in terms of reduction of heart failure hospitalizations or CV death, or the composite endpoint of renal worsening, end-stage renal disease, or renal death in patients with type 2 diabetes. And of course, we're always asked the question, has been alluded to, what is the mechanism whereby these relatively modest drugs for reducing glucose levels that were thought to act via glycosuria, producing glucose excretion from the kidneys, could have such a profound effect on heart failure? And to be honest, we don't know the answer. We have mechanisms whereby there is a promotion of diuresis and natriuresis via the inhibition of the sodium glucose cotransport receptors within the kidney. We cause glucose excretion, particularly in those with elevated blood glucose levels, and we get sodium excretion. But we also see improvements in cardiac function with reductions in preload and afterload, an increase in cardiometabolic efficiency due to metabolic effects within the metabolizing cardiomyocytes, a reduction in left ventricular mass, a reduction, albeit modest, in blood pressure, a reduction, consistent reduction in body weight, and an improvement protection of the kidney. However, preventing heart failure in the background of type 2 diabetes is not the same as actually treating established heart failure. And although we had such positive results in type 2 diabetes cardiovascular risk trials preventing heart failure, the question was asked whether these agents might work in established heart failure. And the small subgroups from these earlier trials that had heart failure didn't give us absolutely convincing results. Therefore, the focus turned to whether the SGLT2 inhibitors would be effective in established heart failure. But also, the question was asked whether they might work in heart failure even without background type 2 diabetes, which was a radical suggestion given these drugs started life as treatments for diabetes by reducing glucose levels. The first major trial was presented only 2 years ago, and that was the DAPA-HF trial, Dapagliflozin for prevention of adverse outcomes in heart failure, published in the New England Journal of Medicine under 2 years ago, November 2019. You see here on the right the primary endpoint, which was the composite of cardiovascular death, heart failure hospitalization, or an urgent visit for heart failure treatment. The reduction in this clinically meaningful primary endpoint was 26%, highly significant p-value. Only 21 patients needed to be treated to prevent one of these major adverse outcomes. In addition, when we look at the trend in terms of the reduction in hazard ratio here, the 95% confidence intervals, we see this difference reach statistical significance within 1 month of starting treatment, showing a very substantial but very early benefit of initiating these agents. The speed with which these drugs prevent cardiovascular death or worsening heart failure really indicate that we should be starting them in our treatments very early so as not to miss the opportunity for protecting patients within the first month. In addition to the primary outcome, the two components of the primary endpoint were also both significantly improved. A worsening heart failure event showed a reduction from 13.7% to 10%, a reduction in 30% in relative risk, highly significant p-values, curves separating very early. But also independently, cardiovascular mortality itself was significantly reduced, a rate of 11.5% on placebo to 9.6% on dapagliflozin, an 18% reduction with the confidence intervals not crossing unity and a significant p-value of 0.029. What was also important, and when this was first presented, there was an amazing clap of applause within the podium in Paris at the European Society of Cardiology, because it showed that the results were significant, not just in patients with diabetes, but also equally powerfully in patients without diabetes. So we had a drug developed for the treatment of diabetes, which acted via reducing glucose levels, showing a reduction in mortality, heart failure hospitalizations in patients even without any diabetes. So clearly there were benefits independent of the ability to be a treatment for diabetes. In addition to the improving these major outcomes, we saw in the DAPA-HF trial also a significant improvement in quality of life. Patients on dapagliflozin were 18% more likely to have symptom benefit, as measured by an improvement in the KCCQ, or Kansas City Cardiomyopathy Questionnaire total symptom score, compared to placebo, with a win ratio of an 18% improvement, p less than 0.001. If we look at either improvements in KCCQ total symptom score of at least 5 points, at least 10 points, or at least 15 points, being substantial clinical benefits, we see all of these thresholds were significantly more likely in patients randomized to dapagliflozin, all with highly significant p-values. In support of this, some patients who deteriorated in their quality of life, a worsening of the KCCQ total symptom score of at least 5 points, was substantially less likely in patients on dapagliflozin, also with a p-value of 0.0001. So in addition to the major clinical benefits, there was major symptom benefit for the patients as reported in the most reliable and commonly used patient-reported outcome, the KCCQ score. There was also interest in whether these effects would be consistent across a range of different background treatments. And if we look here at patients on or not on an ACE inhibitor ARB, and beta blocker at greater than 50% target dose, so the adequacy of background guideline-directed medical therapy, we see no interaction with equal benefits regardless of background therapy. And that's irrespective of whether you have multiple agents on board or not, including an ARNI. So there was no interaction between background therapy and the benefits of dapagliflozin. There was also a consistency of benefit on the major outcome across other key subgroups, such as diabetes status, such as the range of systolic blood pressure, such as whether the etiology of heart failure was ischemic or non-ischemic, the duration of heart failure, whether they're on diuretic therapy or not, whether they're on sacubitril/valsartan or not, whatever the baseline ejection fraction, the baseline level of N-terminal proBNP, or the baseline level of renal function. All of these did not matter in terms of predicting the response to dapagliflozin. And here we see it graphically in terms of the range of ejection fractions, whether we look at the primary outcome or cardiovascular mortality or heart failure hospitalizations or all-cause mortality, we see benefit across the range of ejection fractions from nearly 10% up to 40%, in all cases with dapagliflozin being superior to placebo. Also, in patients who had recent worsening of heart failure, whether the recent worsening was whether there's no recent worsening, a worsening more than a year ago or less than a year ago, we saw equal benefit of dapagliflozin. It was interesting whether the agents were more effective in diabetes patients or the level of diabetic control. And here was an analysis published in JAMA in 2020, and it showed the overall effect that dapagliflozin was better irrespective of diabetes and irrespective of whether the level of glucose was well controlled or not. So if you look at baseline hemoglobin A1C compared to the beneficial effect in terms of reduction in hazard ratio, it's virtually a straight line showing an improvement in dapagliflozin everywhere from baseline hemoglobin A1C of 5 right up to 12. It's important, in addition to efficacy, we look at safety outcomes, and we'd like to see whether it differs between patients with type 2 diabetes and not type 2 diabetes, because of course there might be some effects such as hypoglycemia or diabetic ketoacidosis that may be more important in patients with type 2 diabetes. There was no significant interaction for any of these adverse events, showing patients with type 2 diabetes did not respond in a different way systematically to patients without type 2 diabetes. If we look at any serious adverse event, they were all less likely in patients on dapagliflozin compared to placebo. If we look at adverse events leading to treatment discontinuation, they were less in patients with type 2 diabetes, and a modest but non-significantly significant difference, statistically significant difference in patients without type 2 diabetes. Volume depletion was similar. Kidney adverse events were similar. Fractures were not excessed. Amputations did not have a significant excess. Major hypoglycemia was extremely unusual. It did not occur in patients without type 2 diabetes and had a very low prevalence of 0.4% in patients on dapagliflozin and placebo in the presence of type 2 diabetes. Diabetic ketoacidosis was also extremely uncommon in both patients with and without type 2 diabetes. Of course, this trial was followed a year later with a similar trial of empagliflozin, the EMPEROR-reduced trial that's been referred to, that had this approximately similar reduction in the same composite endpoint of cardiovascular death or hospitalization for heart failure. But when we compare the two trials head to head, we see although the primary endpoint was similar, 0.75, 0.75, there were some differences in the secondary endpoints. First, hospitalization for heart failure was similar, but the renal composite endpoint seems slightly greater for EMPEROR-reduced, but mortality was only significantly improved with dapagliflozin, with cardiovascular death showing an 18% reduction, which was statistically significant for dapagliflozin, but there was only an 8% trend, which was not significant for empagliflozin. We don't know if these differences are significant and real in the long run, but it's very reassuring to have the agent that reduces the composite as well as cardiovascular mortality. In addition to the heart effects, dapagliflozin was tested in a chronic kidney disease trial called DAPA-CKD. And that was a trial of 4,300 patients, also in patients with or without diabetes. And that included patients with chronic kidney disease. When they looked at the primary endpoint, which was a composite of cardio-renal events, including a decline in GFR of at least 50%, end-stage kidney disease defined as a GFR less than 15 mils per minute per 1.73 meters squared, or a need for chronic dialysis and or renal transplantation, or renal or cardiovascular death, what we saw was a very significant protection. The hazard ratio was 0.71, highly significant p-value. You see the number of events reduced from 312 on placebo to 197 on dapagliflozin, showing a near 40% relative risk reduction, and only 19 patients needed to treat to reduce one of these significant renal events. So in addition to protection from heart failure hospitalization and cardiovascular death, there's a protection from renal major adverse outcomes, renal or cardiovascular death. You see here that the secondary endpoints, the combination of heart failure hospitalization or CV death, which was the same endpoint as in DAPA-HF, was also significantly reduced, about 30%, and all-cause mortality was significantly reduced again by 31%, showing a reduction in major mortality events, both in patients with CKD as well as heart failure, irrespective of the presence or absence of type 2 diabetes. So we can conclude that dapagliflozin has a well-established safety profile in patients with type 2 diabetes, CKD, and heart failure with reduced ejection fraction. In the DECLARE TIMI 58 study of high-risk cardiovascular disease, we see no worrying side effect at all, very similar rates of volume depletion, fewer renal adverse events, no difference in fractures, no difference in amputations, no difference in hypoglycemia, no significant effect on diabetic ketoacidosis, a small excess of genital, mainly fungal infections, no difference in urinary tract infections, and no excess of Fournier's gangrene. Similarly, in DAPA-CKD, we see very similar effects. Also, the side effects we worry about, diabetic ketoacidosis, major hypoglycemia, were less likely on DAPA compared to placebo. And in DAPA-HF, we saw a similar result yet again. So the side effect profile was quite reassuring for dapagliflozin in these three major trial areas, all of which showed substantial clinical benefits. Particularly, major hypoglycemia, diabetic ketoacidosis, were not observed in patients without 2 diabetes and were not observed with any significant excess in patients with type 2 diabetes. There are further clinical circumstances we need to take into account when initiating SGLT2 inhibitors so our patients can get the benefit of these agents. It can cause an increased risk of genital infections of the fungal type, and that's due to the propensity of glycosuria causing a high glucose environment that encourages the growth of commensal fungi. So you're advised to advise patients to drink plenty of water and other liquids, urinate frequently, and genital hygiene. These things can be treated with topical medications or the occasional oral medication, and they're usually not serious. Hypoglycemia is fortunately very rare. There is an increased risk when used in combination with sulfonylureas or insulin, but in type 2 diabetes not taking insulin, the risk was very low and almost placebo-like. There were rare cases of Fourier gangrene, a serious illness in the genital region but this was very low and was actually lower on the patients randomized to dapagliflozin compared to placebo. So the most recent guidelines for heart failure published by the ESC in press the first time 3 weeks ago now elevated the SGLT2 inhibitors, particularly calling out these two agents, dapagliflozin and empagliflozin, as the top line with a class 1A recommendation to reduce mortality in all patients with HFrEF. And this is now called the Fantastic Four Foundational Therapies for HFrEF: ACE or ARNI, beta blocker, MRA, and for the first time, the only agent that's not neurohormonally active, the SGLT2 inhibitors, dapagliflozin or empagliflozin. The important thing of these things being put at the same level in the algorithm is that we do not have to wait until the previous drugs have been tried, tested, and uptitrated. The recommendation is that patients start on these four agents as quickly as possible in the way that is safe and appropriate for the patient in front of you. It's adding the art of medicine. We take into account patient characteristics such as the level of blood pressure, the level of heart rate, the level of kidney function, the risk of hyperkalemia and other features as to what's the best agent of these four to start. And in fact, the recommendation is that we start these four drug classes before we take the slower process of uptitrating. Given that dapagliflozin only comes at a single dose in the treatment of heart failure of 10 milligrams, there's no need for uptitration, and it has such a small effect on blood pressure and heart rate. It can be started very early in all patients with HFrEF, probably far more quickly achieving protection than the other more traditional agents, which we used to start first. In summary, dapagliflozin reduces cardiovascular risk across the spectrum of patients with heart failure and cardiovascular disease. At risk for heart failure in the DECLARE TIMI58 trial, the largest, broadest SGLT2 inhibitor cardiovascular outcome trial in patients with type 2 diabetes. In DAPA-HF, the first SGLT2 inhibitor outcomes trial and the only one to reduce cardiovascular mortality. And in DAPA-CKD, the first and only SGLT2 inhibitor renal outcomes trial in patients with and without type 2 diabetes. This shows the major benefit of this agent, and it's now our duty and responsibility to ensure these drugs are implemented in the care of our patients with the cardio-renal syndrome because of how effective they are and how well tolerated. Thank you very much. I look forward to further talks and the discussion.
I think we can take the opinion of Dr. Manchanda, sir.
Well, I think this was an outstanding presentation by Professor Andrew Coates, telling us the use of SGLT2, especially DAPA, in cardio and nephroprotection. And as a cardiologist, I agree 100% with whatever he has said. In our context in India, I think it is more important because we know that we are the diabetic capital of the world. We have the largest number of diabetes possibly anywhere in the world. And it is very rapidly increasing, much more rapidly than in the Western countries. As he said, if 30% of people with diabetes have heart failure, then you can imagine the number of patients. Already, heart failure is a big problem, not only for us, but all over the world. As he said that there have been significant advances. We had three pillars earlier. He told about ARNI or ACE inhibitors, then beta blockers and MRA. Still the mortality is very, very high, and there was a need for a new drug. And I think this is a great addition to the pharmacological therapy of heart failure. I have been treating heart failure for this last about 50 years, and I have not seen any drug which is so useful at all. Initially, it came for the management of diabetes, but I think basically it is a cardiac drug with a pleiotropic effect that it can reduce blood sugar in patients who are diabetic. In non-diabetics, it's not there. Now, you see, the problem in India is another one, that guideline-directed therapy is very, very poor. And one of the reasons, as a senior cardiologist, I can say, is that many of the patients who come to us, they have a low blood pressure, hypertension. And although ARNI and ACE inhibitors are extremely useful, one has to titrate the dose very, very carefully. Even beta blockers at times have to be carefully titrated. So the question is which one to be started first. As he said, one should start all the four drugs simultaneously, but it's not possible all the time. because many of the patients that to come to us are in very advanced heart failure, they have very low blood pressure. So what we do is that we are introducing these SGLT2 inhibitors at a very early stage, because as I said, this is only a single dose, does not have to be titrated, does not have much hemodynamic effect, unlike the ARNI or the ACE inhibitors and also. I think this is a great addition to the pharmacological armamentarium. There may be a small dose of beta blockers, or we cannot even use beta blockers, we use ivabradine. Then we add, of course, we try to use ARNI if the blood pressure is all normal, but if it is very low, then we start with this SGLT2. And as I said, that there is a great advantage. And this is a drug which, of course, not only treats patients with heart failure, whether they have diabetes or not, as he said, irrespective of diabetes or not diabetes, this is a very useful drug. It's very useful for prevention of heart failure. In diabetic, he showed several studies where it has been shown to be preventing heart failure. I wish there will be some studies, maybe I'll have to ask his comments, in patients who are at high risk without diabetes. Will it prevent really heart failure in them? I think it could, but I think more studies are needed. Without diabetes, if patients who are at high risk develop heart failure, whether this will prevent or not. We know that patients with heart failure without diabetes are also affected by this. So I think this is a great use to our armamentarium, and especially in patients who have heart failure with preserved ejection fraction. We have no treatment for this. All other drugs have failed. And as you heard from the previous speaker, that we have this preserved study, which shows that even in patients with heart failure with preserved ejection fraction, it could be useful. Of course, we have shown Dapagliflozin is useful. So I think this is a great advantage of this SGLT2, because so far all drugs have failed except this. And heart failure with preserved ejection fraction is not an uncommon entity. Actually, we have done studies in our institute and found that diastolic dysfunction does occur in a significant number of diabetic patients, and we had no drug. And I think this could be an extremely useful drug in patients who have heart failure with preserved ejection fraction, because there was no other drug. So I think this is going to come in the guidelines soon after that study with preserved ejection fraction with Dapagliflozin. I think all these EMPA and DAPA are interchangeable as far as heart failure and kidney disease is concerned, as has been shown in several studies and all. So I would like to thank Dr. Andrews again. And as cardiologist, I agree 100% with him that this is one of the most significant advances in the management of heart failure that we have seen. This is a drug with very minimal hemodynamic effects, and therefore this is preferred by most of the cardiologists in India, at least. We started even much earlier than sometimes ARNI, and because the blood pressure is low, we are really scared. And I think the addition of this drug has improved the guideline related therapy in our country.
Thank you, sir. Thank you, sir. Thank you very much for your nice comments, sir. You are speaking from your experience. And as you rightly highlighted, the ghost of treatment of heart failure is hypotension. And sometimes we are unnecessarily worried about hypotension. And as you rightly highlighted, sometimes we have to start low and gradually increase. But guideline-directed therapy is really not given to our patients. And we all know the prognosis of heart failure is very, very poor, even poorer than many of the malignancies. And you also highlighted that in this type of patients, sometimes even if these drugs are given, they are given in very low doses. And our approach is to look into the renal outcome, renal output, and gradually keep on up titrating all these 4 pillars, what Dr. Andrew Coates highlighted. And we have seen that people are using very minuscule doses of all these guideline-directed therapy. And if you look into experts' view, they say that you have to keep on increasing till you reach a maximum doses or till the patient is able to tolerate those things. With that comment, I think we will go again to Dr. Andrews Coates and look into his opinions. Over to you, sir.
So, thank you very much. I mean, I agree with the comments. What we have is a major advance And the attractive thing is it has a completely different mode of action. So it's not a replacement for the neurohormonal antagonists and modulators. It offers an entirely new mechanism, which is totally independent. And we also heard the question asked of whether we could prevent heart failure. And the fact that DAPA-CKD showed a substantial reduction in composite endpoints, including a reduction in heart failure hospitalization, it probably does have the ability to prevent heart failure. It's established definitively in type 2 diabetes, but probably also in patients without type 2 diabetes. What is very attractive is the fact for the first time we have a drug with a substantial protective effect on the kidney at the same time as treating heart failure, because we know often we're very limited by poor renal function, and most trials until very recently had a lower limit of recruiting patients of GFR of 30. So if you had a patient with 30 or 25, you wouldn't know what to do. But we've now seen trials with SGLT2 inhibitors that have shown recruiting 30 or even down to 20, we get protection. And so that's a major advantage. So that if we have a very fragile patient, and has been mentioned, low blood pressure, poor renal function, we now have an option that's the most likely to be well tolerated by those patients, and we can give some protection with that. And it may even allow the heart failure to improve enough so that they can then tolerate the more aggressive treatments such as sacubitril valsartan in their treatment later on.
Thank you, Dr. Andrews, for your comments. I think we entirely agree with you. What about heart failure with preserved ejection fraction? Would you like to say that this could be the future for that? It's not coming.
Yes, I think it could. We've never had an effective treatment, and we all know it's only about 3 weeks ago the Emperor Preserve study showed a significant reduction in the same composite endpoint. It didn't show a reduction in mortality, but it did show a reduction in the heart failure events. And the effects seem to work over a range of ejection fractions. So if you put that together with Emperor Reduced and Emperor Preserve, you'd have to say that you can use that SGLT2 inhibitor in all patients with heart failure. We are all awaiting the results of the liver trial, should be early next year, which is a similar trial in HFpEF with Dapagliflozin. And if that's positive, which we all cross our fingers and hope and expect, then we can demonstrate these two agents work both in HFrEF and HFpEF, and suddenly the treatment options for heart failure become a lot easier.
Thank you for your comments. I think with this, we will move on to the case studies, and then we will have discussion on those real cases. And may I invite Dr. Ashu Rastogi to present the first case, and then we'll have the discussion. You heard Dr. Ashu is one of the leading endocrinologists of the country. He is going to present the first case. Dr. Ashu, please.
Yeah, thank you, sir. And thank you for inviting me to present the case. And I will definitely take you to an entirely different aspect of the diabetes and the diabetes treatment in our patients. And that is mainly related to a case which is a case of diabetes with a chronic kidney disease. And as our learned speaker has already mentioned about the Dapagliflozin trial, so this kind of case presentation is not so uncommon that we see day in and day out in our clinical practice. And
you can make them full slide, yeah, please. Thank you. Thank you.
So this is a 68-year-old woman who was a known case of diabetes and hypertension, and she just presented for a routine clinical visit, because she was following the clinic almost every 6 monthly and very religiously. But now she complains of mild fatigue and leg swelling. Otherwise, she was asymptomatic. She was diabetic for 8 years and she was hypertensive for 10 years. So the first question that comes to the mind, that in this scenario, when the patient is complaining of leg swelling and mild fatigue, is CKD rings a bell that probably the patient is having a decline in the renal function. So how common is CKD in this scenario? So maybe Sharma sir, if you'd like to take this question.
Sir, as we discussed earlier also, about 40% of our patients with type 2 diabetes are having CKD as the disease progresses. Thank you.
Exactly. So that is always a challenge. So therefore, it is recommended by all the guidelines, especially the American Diabetic Association guidelines, to monitor the kidney functions at least annually in those patients who are having abnormal renal functions. And it has been seen even by the seminal UKPDS trial that the CKD is not only determined by the estimated GFR, but also by the proteinuria, because we can have few patients who might have proteinuria, which is a sign of a glomerular damage or the mesangial proliferation in patients who are having a normal GFR, but that also signifies a kidney disease. So if we combine those patients who are having only proteinuria with normal GFR and few patients who have a decline in GFR but a normal or no excretion of the albumin, so overall in a lifetime risk of having a nephropathy in a given case of diabetes is around 50%, and definitely it increases with the duration of diabetes. So UKPDS trial showed that the incidence of proteinuria is at least increased by 2% per year with increasing duration of diabetes. And if you have a diabetes duration of around 10 years, the risk is around 25% of the patients will have proteinuria. So another thing was that what are the other signs and symptoms of CKD that a patient can have? Because this patient just presented with mild fatigue and leg swelling. So we have seen in our clinics that they can have varied presentations of CKD that may be related to either even the brittleness of diabetes. A blood pressure which is very difficult to control is again one of the manifestations of chronic kidney disease. A patient who is may sometimes present with a flash pulmonary edema also, just because of a AKI on CKD or a CKD per se itself. So these kind of patients may have varied presentations, and we have to keep our eyes open for these presentations. So when we just looked at the patient, she weighed 55 kgs and she had a blood pressures of 155 by 90 millimeters of mercury in sitting position. And as we were suspecting a nephropathy, fundus was also done, which reveals the AV nicking with cotton wool exudates, which is signs of both hypertension as well as diabetic retinopathy. She otherwise had an unremarkable cardiac examination, but she had diffusely reduced peripheral pulses. And interestingly, she also had a right femoral bruit. She had a trace pulmonary edema. Looking onto the medications history, she was on telmisartan and hydrochlorothiazide, and she was on metformin 1 gram twice a day. Just we wanted to have the record of her lab parameters 18 months back. Her serum creatinine was 1.5 milligrams per deciliter, and just 1 year ago it was 1.6. So then another question comes that within 6 months there was around 0.1 milligram per deciliter. So is this again point of concern for us, and how can we assess her degree of kidney dysfunction? Sir, would you like to just comment over this?
Well, we had to look at both estimated GFR as well as amount of proteinuria and what is happening to the blood pressure also. And as you rightly highlighted, there are so many symptomatology which are also to be looked into. Thank you.
Yeah, thank you, sir. So the one way to assess the kidney dysfunction is definitely the glomerular filtration rate. And now we have the kind of equations which have been validated. One is a Cockcroft-Gault equations. But the American Diabetic Association recommends either using of CKD-EPI for the calculation of estimated GFR whenever we see a patient with diabetes, or even MDRT. So both have been found to be validated for the measurement of eGFR. But that habit has to be made. So whenever we see a patient of diabetes, document creatinine, but also estimated GFR. So back to the patient again. So her creatinine was checked at this point. So it is now 1.7 milligram per deciliter. And if I go back, just within around 18 months, her creatinine has increased by 0.2 milligram per deciliter. And her creatinine clearance was now 27 milliliters per minute by Cockcroft-Gault equation. And by MDRD, it is 32. So we can quantify CKD. So now we have a classification. Even the Rifle criteria is also there, by which we can quantify CKD. So what next? That's the burning question. So this is the stages of CKD. So initially we'll have the GFR, which is increased in a given patient with diabetes. Usually when it is mainly true for type 1 diabetes patients who follow this kind of a pattern, where initially they would have increase in GFR with increase in the size of the kidneys, maybe around 20%. Later on, they enter into stage 2. Again, they would be asymptomatic, but the GFR falls to less than 90. They might or might not have proteinuria, but at stage 3, they might start developing symptoms. So this is the stage usually that brings the patient to the clinic when the GFR falls less than 60, as in our case also, where she presented with the swelling in the legs, and then it might further progresses. And it has been seen that those patients who are having microalbuminuria, almost 1/3 of the patient progresses to the macroalbuminuria stage, if not properly intervened within just 3 years. Then finally into the stage of kidney failure. What is important is we have to first identify some reversible causes of this decline in the renal functions, for particularly the use of certain kinds of NSAIDs or toxic medications, which can lead to a rapid decline in the GFR. About volume contraction, because she was an elderly lady, where maybe she might be having a poor intake, that might be responsible for volume contraction, or she might be on some other drugs that might be responsible, or some obstructive neuropathies, maybe because of autonomic neuropathy with bladder dysfunction or urinary obstructions. And other drugs which have been implicated in this reversibility would be the aminoglycosides and amphotericin B and IV radiocontrast agents also. So in these patients, we identified and treat factors associated with the progression of CKD. One was hypertension, as rightly pointed out by Sharma sir. So her blood pressure was high, 150/90, as per current standards of treatment of hypertension in patient with diabetes. So we need to escalate the antihypertensive drug. The proteinuria need to be taken care. And now it has been well proven by the DAPA CKD trial that these drugs are also useful in reducing proteinuria or preventing even the occurrence of new onset proteinuria. Then the glucose control again is very important. So the target blood pressure that was kept in this patient was less than 130/80. Yes, sir. And we can consider several antihypertensive medications with different mechanisms to control our blood pressure, which might include ACE, ARBs, diuretics, CCBs, especially maybe some kind of CCBs which acts both on L and T calcium channels, and hydrochlorothiazide, which might be less effective for GFR less than 20. So as I was mentioning regarding proteinuria, this is one of the last slides, that it is the single best predictor of the disease progression. If patient is having microalbuminuria, that means albumin excretion of 20 to 200 micrograms per minute, or if you are taking a 25 urine sample of 30 to 300, that is a significant predictor of future progression of the disease. But now we have interventions and drugs that can prevent the further progression. The target A1C that we like to keep in this lady would be around 7%. But yes, she is elderly. She might be at risk of hypoglycemia. We might relax a bit considering the risk of hypoglycemia elderly. And the declining kidney function may necessitate changes to diabetic medication, especially as she was on metformin. We might discontinue metformin because she is now in CKD stage 4 and she might require some other oral anti-diabetic drugs or even insulin for that. So thank you, and back to Sharma sir.
Thank you, Dr. Rastogi sir, for a beautiful illustration of how our patients of type 2 diabetes are developing chronic kidney disease and what are important pointers to be looked into and how to manage them. So beautifully done. But my single comment will be that now we started talking about non-proteinuric diabetic kidney disease also, where tubulointerstitial you can say problem and is there, and many of our diabetic patients are also having that type of problem. So, and probably this SGLT2 inhibitors may not be as effective as in a glomerular disease. That is, I think, is the main difference there. Thank you. Manchanda sir, your comment, and then you can invite to the next case discussion. You are muted, sir. Please unmute. Yeah.
Am I audible now? Yeah.
Yeah, now you are audible.
Well, it was a nice case presentation, but as he said, you see, diabetes has to have a holistic treatment. You talked about hypertension, you talked about chronic kidney disease. But if a patient, I'm a cardiologist, of diabetes and hypertension comes with pedal edema, one has to think of heart failure also. So one would like to do the echocardiography in this case also. And it's possible that the ejection fraction is normal. So one has to do the NT-proBNP also, because pedal edema is also a presentation of heart failure also, even with left heart failure. So that is one. And secondly, one has to look after, of course, the lipid contents also. And therefore, I think if the lipids are high, one has to really treat them and all. And the guidelines are that above the age of 40, everybody should get that high dose lipids, statins and all that thing. So I think he said it has to be a holistic sort of treatment and all. Absolutely. Kidney disease, yes, very important, and one has to really take but also one has to choose the drugs, antihypertensive properly. And I think it's a holistic treatment of hypertension, of diabetes and its complication, which is going to help these individuals.
We can also take the opinion of Dr. Andrew's quote as we looked into this type of patients, and there are now more and more data emerging. The important link between chronic kidney disease and hospitalization for heart failure. So these two diseases are, you can say, deteriorating each other. So cardio-renal or renal cardiac syndrome is there. So Dr. Andrew, your opinion regarding this type of patients?
I certainly agree. I mean, what we really need to do is realize that these diseases all make each other worse. So the presence of CKD, type 2 diabetes, and heart failure are very common. And if you get one in a patient and two, it's highly likely the third will come. Increasingly, there's a trend now to having joint clinics where you have hospitals where they specialize. There's often a joint cardio-renal clinic, and diabetic patients are extremely common in those clinics. So I think you need a very high index of awareness of the possibility. So I totally agree, Dr. Ramachandra, we really need an echo, we need an evaluation of natriuretic peptides, and we need a good evaluation of renal function to protect this patient most adequately.
Absolutely, sir. Sir, you can invite our next speaker also.
Yeah. Now let's hear from a cardiologist. And may I invite Dr. Deepak Ranjan Das, a leading cardiologist, to present the second case.
A field of cardiology and endocrinology. My sincere respects to Manchanda sir, who has been a teacher of my teachers. And I'm not going to present a case, but I'll basically highlight three important aspects of heart failure management in Indian context, which have become actually revolutionized after the availability of SGLT2 inhibitors as one of the 4 pillars of heart failure drugs. The first issue is, in Indian context, majority of heart failure patients are not treated by cardiologists but by physicians. And every heart failure drug needs to be titrated, except the SGLT2 inhibitors, which do not need any titration. That's why we can expect many of the physicians to be actually aware of the benefits of SGLT2 inhibitors and be more liberal in using these medications in heart failure therapy. The second important point is more than 50% of our patients belong to low socioeconomic status. And when we think of heart failure therapy persisting for years, the cost of therapy becomes a serious impending factor. But amongst the SGLT2 inhibitors, Dapagliflozin being off patent, the cost of therapy of initiating one of the 4 pillars of heart failure therapy has actually substantially come down. So providing more flexibility of using all the heart failure and anti-heart failure drugs. And the aspect is many of our heart failure patients, when we see them, have systolic blood pressure hovering on 100 to 110 millimeter of mercury. And we had two fantastic drugs during last few years. One is ARNI, another is SGLT2 inhibitor. One significant disadvantage that we face with ARNI is unless you start it with a very low dose, like say 50 milligram or even in even subtherapeutic doses of 25 milligram twice daily, you see most of the times you come across serious hypotension in the patients.
I think we lost Dr. Das. His internet is, I think, is not properly. So we can.
Hypotension sometimes hospitalized. So these diseases we don't cross with inhibitors. So mind these three important with SGLT2 inhibitors are going to revolutionize heart failure therapy in Indian context and more so amongst quite a lot of heart failure patients who are poor and belonging to low socioeconomic status.
Thank you, sir. Thank you very much for your experience and your comments. I will just say one thing, that we should realize that at the time when a patient is coming to us for heart failure, he is already very advanced heart failure, because we know the stages of heart failure: stage 1, stage 2, stage 3, and stage 4. So our physicians are getting them very late. And as you rightly highlighted, many a times their blood pressure is so low that they are not given guideline directed medical therapy. And even if that therapy is given, many of them are not able to afford it, or many of them are not able to up-titrate it accordingly. So guidelines are telling us that every 2 weeks or so, you keep on up-titrating till you reach a good level or where the patient can afford them. But we can take the opinion of Dr. Andrews Coates in this situation. Over to you, sir.
Yes, I think it's very important we get as much protection as possible. And it's probably, we haven't got definitive trials, but it's probably preferable to have a little bit of each of the four major drug classes rather than pushing one class up to the top dose at the expense of the others. If you have a limited reserve of blood pressure or in kidney function, then clearly I'd prefer to have a little bit of each dose. And the SGLT2 inhibitors are the easiest drugs to give, because a single dose, very little effect on blood pressure. The only concern is that the GFR, when you give one of these agents, the GFR falls immediately due to the hemodynamic effect of reducing perfusion pressure in the glomerulus. And the danger is that you might then get worried and stop the drug, whereas actually that effect is just showing the drug's working. And the most important thing is if you do see a fall in GFR after you start dapagliflozin or empagliflozin, just check the GFR again. And if the patient's well and the GFR is stable, carry on, because that then protects the kidney. And I think with time, you might find that the patient improves enough to tolerate a higher dose of an ARNI or beta blocker. So definitely, I think gentle initiation and early use of SGLT2 inhibitors is very important.
Dr. Manjender, sir?
Yes, I think I agree. We get patients, as I said. Am I audible?
Yes, sir, you are audible.
I also lost internet for a short time. I agree with Dr. Das. You see, we get patients who are in very advanced stage, and these patients really have a lot of low blood pressure. And although one can start these drugs very carefully, especially the ARNI or the ARBs, but I think the physicians, as you said, there are not many cardiologists who are treating. Physicians are really scared to start these drugs, especially blood pressure is less than 100. So at that time, I think this SGLT2 inhibitors are extremely useful, and sometimes we have started as the first drug itself. I have started a patient whose blood pressure was 90 or 85. Many times this is there. You can't even dare to start the beta blockers. You start maybe a small dose or ivabradine, which has no effect, and then the second is SGLT2. As they improve, then you start adding the other drugs and all, because other drugs do cause initially hypotension, especially the patient is sick. You cannot take off the diuretics. Of course, the best way is don't give too much diuretics once they are taking this SGLT2. One is to decrease it. And that is, I think, one of the best methods of avoiding hypertension. And therefore, one should see that a patient is not hypovolemic at all. But I think I will agree with Dr. Andrew. It's best to start the small dose of all these 4 drugs simultaneously, because then the benefit is maximum. This has been shown in hypertension treatment also now, that you can give 1/3 the dose of 3 antihypertensive, because they act through different mechanisms. As I said, the mechanism of hypertension, of heart failure is different. And all these drugs are acting at different levels. So it's best to combine these drugs so that all the sort of pathophysiological pathways of heart failure are controlled. So I would agree with Dr. Andrews. The best is to start with this. In our country, you see, SGLT2 were very, very costly. So that was one of the important limitations, and patients just could not afford it. Even if they started, they will not. But now, you see, there are several companies which have made these very, very cheap. So I think these drugs are extremely useful for Indian heart failure patients, whereas guideline related therapy is very limited. Actually, many studies have shown that it is hardly 10% of patients who get guideline related therapies. These are mostly the side effects of the drugs which these patients feel or their doctors feel and all. So I think SGLT2 are a very good addition because it gives confidence. I have seen patients taking SGLT2 as the first drug. Their blood pressure improves, then they start giving them ARNI or the beta blockers and all things. So this is extremely useful. But one thing I would suggest is that we should decrease the diuretics as we start this SGLT2, because hypotension is usually caused in those who are hypovolemic. And most of these patients are really given very high doses of diuretics, and that should be avoided. But I think this is very important to give them this. And as I was saying earlier, that it may be even good to prevent heart failure. All diabetics with high cardiovascular risk or heart disease should be given. This is a class 1 indication, so that the prevention is the best policy. But even if a patient has advanced failure, I think these drugs are extremely useful, and they are possibly better tolerated than other drugs. That's the impression that I have.
Thank you, sir. Thank you very much. So the take-home message is that we should start treating them with all the 4 drugs, maybe with very low doses, and gradually up-titrate. And it is seen many times that once your patient is having low blood pressure, but once you are giving them and started up-titrating, patient improves, and then his blood pressure may remain same in spite of continuously up-titrating the doses of all the 4 pillars of hypertension, heart failure. So with that, I think we can take the questions if there are any in the chat box. Let me see if there are. Sir, there is a question. Patient age 65 years, left ventricular failure, CKD, pedal edema, abdominal edema, and diabetes from 30 years, 3 block PTCA done, unable to move from one place to other place without support. Can we use SGLT2 inhibitors to him? So I think grade 4 heart failure and long history of diabetes, and patient is really significantly incapacitated. So Dr. Andrew and Dr. Manchanda, sir.
Yes.
Well, I was happy to start off. We really have very few treatments that have been proven in trials in this type of patient. I guess I'd like to know what the treatment of the diabetes is, because my biggest concern is that we have no experience of giving these agents in the background of insulin treatment, so that could be a problem. And if they're on sulfonylureas, it could be a problem. If we don't want diabetic ketoacidosis. But as long as we're avoiding that, and the person's very limited with advanced heart failure, I think it's worth a try because we have very little other to offer this person. And it's a very easy drug to start, and we can stop early if there's any difficulty.
Sir, Dr. Manchanda, any comment from your side?
Yeah, I agree. You see, such cases have been excluded from most of the trials. But we have seen that even in moribund conditions, this is again, there's no data that we have published it, but even these very sick patients really respond to these drugs very well. In these sick patients who are really having very advanced kidney disease and heart failure, I think again SGLT2 will be one of the ideal drugs to give, not only for diabetes, but also for heart failure and all. And there, I think it can be easily given. And we have seen patients, once they improve, their ejection fraction improves, then they can really be mobilized and all that thing. So I think these are also cases, although they are not really in the most of the studies which are included, but we have seen that very sick patients also, even ejection fraction very low, they have been excluded from the studies because they are very, very sick patients. They are not supposed to, but we have seen that these patients also benefit and all. So I think this is an ideal patient to start this drug and all, apart from the other rehabilitation and whatever else one can give for the things and all. So I think these patients should be given. Otherwise, we can't write them off, these patients, you see, because these patients have something correctable. I don't like to write off such patients, although they are not in the studies. And studies have to have exclusion criteria, a large number, otherwise they won't get the positive results. But I think one should extend it to the clinical patients, and that's what we have seen, that they could be given easily, and they tolerate it, most of them, and many of them improve also.
Thank you, sir. Thank you very much. So the second question is, which are synergistic drugs with SGLT2 inhibitors from Dr. Dhawan from Mumbai? Synergistic drugs with SGLT2 inhibitors.
Well, it depends what the aspect is. If for the treatment of heart failure, we know that the SGLT2 inhibitor works equally well, whether the patient's on an MRA or not, whether they're on sacubitril/valsartan or not. So they're synergistic in that they both together aid the reduction in mortality and heart failure hospitalization. If we're using the agents for glucose control, then it's synergistic with other glucose-lowering agents. But I guess in this symposium, we're not really thinking about glucose control so much as organ protection. When it comes to organ protection for the kidney, I'm not sure we've had any other trial that's demonstrated the same degree of kidney protection. So I'm not certain about that one.
Thank you, sir. As an endocrinologist, I can just comment that there are now trials which are looking at combination of SGLT2 with many other endocrine, or you can say anti-diabetic drugs. Recently concluded ADA just 3 months back, where Dr. D. Franjo has highlighted make my match for this oral anti-diabetic and other anti-diabetic drugs, and where he highlighted a combination of SGLT2 and GLP-1 receptor agonist. Then Dr. Chantel from Belgium also highlighted combination of insulin with SGLT2 inhibitor, but these are not heart failure patients. These were diabetic patients. So synergistically, you can combine SGLT2 with many of our other anti-diabetic drugs. We are not talking about heart failure here, but for heart failure, as Dr. Andrews highlighted, we don't have those type of studies where insulin is on board and then you are looking into the effect of these drugs. So the third question is, can SGLT2 will replace DPP4 inhibitors in diabetes therapy? And then the other comment is, yes, then what are the benefits over DPP4 inhibitors? I can take the opinion of Dr. Andrews, then I think as an endocrinologist, I will also give, and we can invite opinion from Dr. Ashu Rastogi also here.
Well, I would prefer to defer to the endocrinologist, diabetes specialist. I specialize in heart failure, and I wouldn't like to mess around with the diabetic treatment. I would just like to make sure the patient's taking the SGLT2 inhibitor.
Dr. Rastogi, are you there? Dr. Ashu? Well, I think I can give a short answer to that. Dear friends, earlier we were having DPP4 inhibitors before the arrival of SGLT2 inhibitors like sitagliptin, saxagliptin, vildagliptin, etc. And we were not disappointed by their effectiveness. But now when there are studies comparing SGLT2 to DPP4 inhibitors, we can say on one hand, the HbA1c reduction with SGLT2 inhibitors are better than DPP4 inhibitors, but DPP4 inhibitors are considered to be cardiovascular safe. This is a very technical term. Cardiovascular safe means they do not increase, but they do not decrease the cardiovascular outcome. But here you have drugs like SGLT2 inhibitors, which are having so many benefits, not only reducing MACE outcome, but also hospitalization for heart failure, as well as Dr. Andrew highlighted, treatment of heart failure, as well as protecting the kidney of our diabetic patient. So I don't think there is any comparison between DPP4 inhibitor and SGLT2 now after this landmark trials of cardiovascular outcome trials as well as heart failure trials. And we all are having now first choice as SGLT2 after metformin in our diabetic patients, and ADA guidelines are clearly telling us that if you have a patient of diabetes with high risk of atherosclerotic cardiovascular disease or heart failure or CKD, you have to combine metformin with this SGLT2 inhibitors or GLP-1 receptor agonist, irrespective of baseline HbA1c and irrespective of your target HbA1c. So if your patient is having good HbA1c target achieved, then you have to remove other drug and bring in SGLT2 inhibitor in their place. Thank you. Any comment from Dr. Manchanda, sir?
I agree with Dr. Andrews. You see, we look after heart failure, but as you said, they can be combined with any other anti-diabetic drug. The best is, of course, as you said, GLP-1 analogs, because they also really contribute to decrease in the cardiovascular mortality and all. But I think, as you said, insulin can be there, and the other drugs could also be, which are cardiac safe, can be combined with that, because you have to make a patient euglycemic or keep his HbA1c in the usual control. So insulin, but GLP-1, as you said, possibly are the best drugs and all, and DP4 also are extremely good drugs. They can be combined. So I think that is one part. But from the cardiac point of view, they can also be, they are useful in addition to all the other heart failure medicines. For example, if you give them even over ARNI, as Professor Andrews showed us very clearly, that they have a benefit. So I think additive effect is known in cardiovascular, but diabetes, as you said, has to be controlled. And if the diabetic control is better, there is some data to show that these patients behave better. So
thank you, sir.
I agree with you, what you said.
Thank you. Dr. Ashu Rastogi, are you there? And Dr. Dash, if you have any comments regarding all these three questions, you can, in short, take these questions and your comments.
I'm there, but I concur with Manchanda sir and you also, so I need not to have any additional comments over that.
Thank you, sir. Dr. Das, you have any final comment here?
As to one of the questions which was asked, whether SGLT2 inhibitors are going to replace DPP4 inhibitor, I think every drug will have its own utility. Absolutely. But so far as utility of DPP4 inhibitors in cardiovascular context is considered, they are in fact the first set of anti-diabetic drugs in whom the CVOTs were actually designed. So they opened up a whole new vista for finding out the cardiovascular outcomes in anti-diabetic drugs, and they are quite safe in patients of heart failure. So they might not have the mortality advantages of SGLT2 inhibitors, But so far as management of diabetes in heart failure patients are considered, they are quite useful as well.
As a caveat of saxagliptin, sir, because saxagliptin
Yes.
in sevortemy has shown 27% increased risk of
Increase in heart failure.
Yeah, but cardiovascular outcome was okay, but heart failure was more. And then one last question is there, sir. What is the mechanism of action of all these beautiful, you can say, mechanism of actions are, what is the mechanism of action of this beautiful group of drugs, SGLT2 inhibitors? We can take opinion of Dr. Andrews as well as Dr. Manchanda.
Yes, it's really a very difficult question. I mean, they have pleiotropic effects. I mean, they work in type 2 diabetes. They, we've seen reduction in cardiovascular mortality with empagliflozin. They work in heart failure, even without diabetes. They work in CKD. So what's the mode of action? Is it on the kidney? Is it on the heart? Is it on the blood vessels? Is it on the neurohormones? Is it on metabolism? It may be a general effect on cellular energy stores. To be honest, we don't know. The beneficial effects are seen within a month. That's quite consistent. So I suspect that it's not via a slow process of left ventricular remodeling. I think there's a quicker process, and I wish I knew exactly what it is. People have theories, but I honestly don't know the answer.
You have shown a slide where you have highlighted some of the mechanism of action, like reduction of HbA1c, weight reduction, blood pressure reduction, and then preload and afterload reduction. Those are considered to be now established mechanism of action. But still people are arguing whether there is an increase in erythropoietin from the kidney, there is a decrease in uric acid, there is effect of this sodium hydrogen exchangers, which are taking, you can say, increasing sodium and calcium in the cardiac myocytes. And then if you are using these drugs, they may be reducing sodium and calcium in the cardiac myocytes and then providing benefits to our patients' myocardium. Dr. Manchanda, you have any comment?
Yeah, when we have so many hypotheses, the answer is we really don't know. If we knew it, we'll say there is only one. You always say blood pressure reducing and all. I think those are really not very important. Diuretics would have done better than this. So I think we have only hypothesis. We do not know it.
Yes.
It seems it is working at a cellular level, and I think that has to be clarified and all. As you said, cardiac remodeling and all.
Yeah.
Maybe nephro remodeling. We have no idea really, but I think the work is going on. But it seems to be a multifactorial thing. But it is surely at a cellular level, and one has to really know about it finally. There are so many hypotheses, but none of them explains it completely. If you even combine it. So I think if you ask me, we really do not know the mode of action. There are hypotheses, and I think further work might tell us how it works. But even if we don't know how it works, it doesn't matter. You see, I have been following some of these so-called Ayurvedic indigenous drugs. They work. And the mechanism we have not even understood till today. So I think it's not important. As long as the drug is safe, has no side effect, and is clinically beneficial, one can use it for the clinical condition. The mechanism may come on later. We may get to the answer, we may not get the answer, because it's a pretty complicated thing. It is surely at a cellular level, but the answer is we really do not know. There are only hypotheses.
My last comment may be that they are not diuretic, because if you compare them to diuretics are reducing intravascular, you can say, volume. But here, these drugs are reducing interstitial volume, and that's how they are having more better effectiveness here in comparison to diuretics. So we can go to our host here, because there is no further question, and we can take their opinion as well as their ideas. Thank you. Over to you, sir.
Dr. Samir.
Swapnil, Dr. Swapnil, you are, I think, unmuted. You are muted. Please unmute yourself.
No, thank you, sir. We have no comments from my side. I'll hand it over to my colleague, Mr. Sashi Bhushan. He shall do the needful, sir.
Thank you very much, Dr. Samir. First of all, good evening, respected Professor S.K. Sarma sir, Professor S.G. Manchanda sir, Dr. Ashu Rastogi sir, Dr. Dapagliflozin sir, and Professor Andrew Coates, all esteemed doctors across the country who are attending the program. Good evening, Dr. Samir, entire medical team. Good evening, all our metabolics family team members. Now, I would like to say that today was a great day because we are less than 100 hours from World Heart Day. World Heart Day is on 29th. We are less than 100 hours, and today was a really great day because I would like to say, sir, today was one of the most spectacular event I have watched so far. I have attended so far. More than 2,552 doctors showing interest. 2,552 doctors showing interest and attending the program. Speaks grandness about the event.
Great.
And it is really a great achievement, sir, to rope in so many stalwarts like all of you in one single platform, in one program. So once again, sir, thank you very much to all. Sir, I would like to quote a few things here, sir. Dapagliflozin, as you all have said, sir, dapagliflozin is a molecule with huge pleiotropy benefits. Earlier, ACE inhibitors, ramipril, statins, then ARBs used to have pleiotropy benefits. Now there is an anti-diabetic molecule with pleiotropy benefits, huge pleiotropy benefits. And Professor Andrew Coates said all these pleiotropy benefits can be seen as early as 1 month. Within 1 month of its administration, the benefits can be seen. Now, sir, I have heard Professor Andrew Coates in one of the conference where he said, you add a dapagliflozin, add a life. Now, looking into the benefits, yes, sir, he has said, sir, probably Professor Andrew Coates remembers this, add dapagliflozin to add life. And sir, this is a wonderful, you can say, sir, this molecule, looking into the benefits, it can be recommended into heart failure patients with or without diabetes. It can be recommended into diabetes patients with or without heart failure. It can be recommended in CKD patients with or without diabetes. And it can be recommended in diabetes patients with or without CKD. Now, this is a wonderful molecule, sir. And sir, there is a story why we were 1 month delayed into the market. Sir, we were 1 month delayed because our R&D scientists, they are looking for dapagliflozin propanediol monohydrate, which is the innovator salt. And due to their efforts, we launched with the dapagliflozin propanediol monohydrate, which is innovator salt, which is bioequivalent to innovator, and our release pattern is linear. Sir, I would like to quote here, sir, we have an aspiration to make this Dapanorm #1 brand. We would seek blessings of all these stalwarts who have attended the program and seek support from all the doctors who are attending across the country. Once again, with this, we would like to thank Professor Andrew Coates, Professor SK Sharma sir, Professor SC Manchanda sir, Dr. Ashu Rastogi sir, Dr. Dapagliflozin Das sir, Dr. Samir, our SBU head Pasa Bhai, our NSM Raghavendra ji, all our senior leaders of metabolics family who are in the field, all our field colleagues, Mr. Swapnil Motewar, and as well as our technical support team, without whose support this program would not have been a grand success, sir. So with this, I would like to thank all once again for making this program a success, and I pray for great health of all the panelists, all the doctors across the country in these challenging times. May Almighty keep everyone safe and healthy. With this, thank you again, sir. Thank you very much for giving this opportunity to be associated.
My last comment will be that it is not only adding years to your life, but those years are healthy years without morbidity.
Yes,
that is important. Thank you. Thank you. Good evening.
Thank you. Thank you very much.
Good evening, everyone. Thank you.
Thank you, everybody.
Good evening, Andrews. Thank you. We liked it. Thank you very much, Dr. Sharma.
Thank you, sir.
Thank you. Thank you.